Welcome, everybody, to our third session of the Solid Talks. I'm really happy that you're here today because we are going to talk about a very important issue, which is drug use related stigma and discrimination. And Yifan Yu from Shanghai Mental Health Center um, has edited a book last year. And this book was published earlier this year in 2025. And the book is called Breaking the Silence. We are very interested to hear more about your book and invite you to share some thoughts about it. So the floor is yours, Yifan.
Okay, so I'm gonna share my screen here. I have a PowerPoint slide. So if it's okay, can everyone see my PowerPoint?
Yes.
Okay, that's good. So this is the book we published. What's wrong with the background? Anyways, so good afternoon or good evening, depending on where you are. I'm Yifan Xu from Shanghai Mental Health Center. Thank you all for joining me for this solid talk. Tonight, we will dive into the book Breaking the Silence, Confronting Stigma and Substance Use Disorder, exploring how stigma affects individuals, families, and communities, and what we can do to reduce it. So, uh, this is a quick word about me. I will try to make it short. So I am a research assistant at Shanghai Mental Health Center, and I'm also a medical social worker. I support patients with substance use disorders and gambling issues, and I've done field research at detox centers, working with people using substances like MDMA. My work bridges research and practice, helping develop outpatient programs and training courses to improve SUD care. With that background, let's jump right in and set the stage for today's discussion. So we'll start with a brief introduction to the topic. Substance use disorders are complex issues that affect not just individuals, but also families and communities. One key challenge we will focus on today is stigma, how it operates and why it matters. Over the next few slides, I will set the stage for today's talk, how stigma and substance use disorder intersect, and why breaking the silence is so important. So why do we talk about stigma and SUD? First of all, stigma remains one of the biggest barriers to effective addiction treatment and recovery. Even though substance use disorder is a medical condition, people with this disorder are still often seen through a moral or personal lens as weak, irresponsible, or dangerous. These misconceptions cause deep emotional harm and social exclusion, preventing many from seeking help. That's why we need a more nuanced and compassionate understanding of this disorder when grounded in science, but also in empathy. So here's a quick overview of the book itself. These are all the chapters we have in the book. So it has 8 chapters, each addressing a key aspect of substance use disorder and stigma. So these chapters range from defining stigma and SUD, substance use disorder, and understanding its mechanisms to exploring interventions, real world case studies, and behavioral addictive disorders such as gaming disorder. So throughout today's presentation, I will highlight the main points from these chapters to give a clear picture of both the problem and potential solutions. So let's have a look at the roadmap of today's session, and we will move through the material. So about today's presentation, we will start from understanding stigma, what it is, how it works, and why it matters. This is essential because before we talk about substance use disorder or interventions, we need a shared understanding of stigma. Next, we will explore the substance use disorder itself from its biological, psychological, and social dimensions. Only by understanding both the condition and the social response to it, we can see the full picture of how stigma impacts the recovery. After that, we will look at the consequences and interplays and the interplay of these two forces. And then we will review strategies and success stories for reducing stigma, drawing lessons from policy, practice, and examples from around the world. Finally, we will introduce behavioral addictive disorders such as gaming disorder and discuss how individuals, families, and communities can take collective actions. So this is the first section, understanding stigma, and it is the key before we explore how it interacts with addiction and recovery. When I began writing this book, one of the first question I asked myself was, where should we begin? I chose to start with stigma, not substance use disorder, not treatment, not recovery, because stigma is the invisible force shaping how all of those experiences unfold. The word stigma here comes from an ancient Greece, as you can see on the slides. I cannot read Greece. So this word referred to a physical mark on brand or brand burned out into the skin or signal crime. These marks made moral judgments visible. Today, we do not carve marks into people's skin, but we still mark them. We use language, stereotypes, and systematic barriers to carve people. So, what exactly do we mean when we talk about stigma? Let's look at how scholars have tried to define and explain it. Over time, researchers have developed different frameworks to understand how stigma works. Goffman first classified it into three types related to the body, to character, and to group identity, what he called tribal stigma. Later, Jones and colleagues outlined six dimensions and that affect how intense or visible stigma becomes. For example, whether a condition is easy to conceal or seen as threatening. Link and Phelan built on these ideas, showing that stigma as a process, which includes labeling, stereotyping, separating, and discrimination, all of which rely on power to sustain equality, hence the plus power on the slides. And then more recently, evolutionary and anthropological perspective reminds us that stigma is not only psychological, but also social and moral. It reflects what a society values and what it rejects. So now let's look at the different forms of stigma. We usually talk about three main forms or like types of stigma. The first one being structural, and the second one being public. The third one is self-stigma, or some scholars call it internalized stigma. The first one, structural stigma, is when laws and systems reinforce inequality, like employment restrictions or healthcare barriers. The second one, public stigma, is society's negative beliefs and attitudes, such as seeing people with SUD as weak or dangerous. Self-stigma, when individuals internalize those beliefs, leading to shame, guilt, and self-belief. So that's why it's called internalized stigma by some scholars. And Link and Phelan describe the mechanism here. Someone is labeled, connected to a stereotype, treated as others, and then finally face the status loss or discrimination. And then these are all sustained by power. So this diagram illustrates how these forms interact with each other. As you can see, the top one is the structural stigma. It institutionalized both the public stigma and self-stigma. It is actually a circle, one that can be broken only by addressing each level simultaneously. So here is a closer look at how stigma operates as a mechanism. It often begins with a label, meaning identifying someone as different. And then the label gets attached to a stereotype, connecting the person to negative traits. Next is separation. It draws a line between us and them. And then finally is the discrimination, when these attitudes turn into unequal treatment. So this process can be self-reinforcing. Once discrimination occurs, it strengthens the label and stereotype, and keep people trapped in exclusion. So to fully understand stigma, we also need to see it through cultural and anthropological lenses. Stigma isn't just about attitudes, it's about morality and identity. It threatens the values that define who belongs in a community. So in Chinese culture, for example, the concept of 面子, which basically means face in Chinese, links moral worth with social standing. Losing face, 丢面子, can cause not only emotional pain but also physical and social distress, a process sometimes described as social somatic. Um, Anthropologists call this the moral career of stigma, which means how a person's social identity shifts as they move through experience of labeling, exclusion, and resistance. These cultural meanings shape how people experience and respond to stigma and how recovery itself is understood. Stigma has profound consequences across multiple levels. At a structural level, it's limited access to healthcare, employment, and social participation. Psychologically, it can lead to depression, anxiety, and lower self-esteem. Socially, it isolates people from families and communities. And for recovery, stigma can delay treatment or make people drop out earlier. Importantly, these effects don't stop with the individual. They ripple outward, affecting families, communities, and the whole public systems. So this figure includes targets here. That means the affected population. So you can see the bottom is people with behavioral disorder. In this case, people with substance use disorder, and then the general public, and then the upper level as the professionals. So the stigma doesn't operate in isolation. It affects the whole community here. In the next section, we will turn to substance use disorder and to understand the condition and see how these social forces interact with biological and psychological process. You here. So what is SUD? When we talk about SUD, it's actually a global health concern. According to the World Health Organization, SUD accounts for roughly 1.8% of the global disease burden. To give that a bit more context, this is measured using something called DALYs, the ALYS, or disability adjusted life years. This is measured combining years lost to premature death and years lived with disability. When we look at SUD through this lens, the picture is uneven across the world. For example, the disease burden in parts of Europe is nearly 5 times higher than in regions where alcohol use is restricted or banned. So this means that biology alone doesn't explain everything. It's related to culture, policy, and social norms. And so, what is a substance? It includes both natural and synthetic products that alter perception, emotion, or behavior. Importantly, use the substance itself is not a disorder. It becomes a disorder when it leads to significant impairment or distress in a person's life. Then it leads to the next question. How do we diagnose SUD? So when we diagnose a mental disorder or mental illness globally, we have 2 main systems. The first one being the DSM-5, Diagnostics and Statistic Manual of Mental Disorder, 5th edition. This is developed by the American Psychiatric Association. And the other one is the ICD-11, the International Classification of Disease, 11th revision, published by the World Health Organization. The DSM-5 is usually used in the North America, and it defines SUD as a single diagnosis based on meeting 2 or more or of 11 criteria. So these criteria, I have a picture of the 11 criteria here, include using more than intended unsuccessful attempts to cut down, spending a lot of time obtaining or using substance, cravings, and problems at work or in a relationship. It also covers psychological aspects like tolerance or withdrawals. The ICD-11 use a different approach. It's classified disorders by substance types like alcohol, cannabis, something like this. And while there is no single checklist chart, it also focuses on dependence and health risk. This helps policymakers of clinicians consider regional and cultural context more precisely. So, in short, DSM-5 use one checklist for any substance, and ICD-11 differentiates by substance type, but both is focused on dependence and related health risks. And then, so why does SUD happen? Substance use disorder doesn't come from a single cause. It arises from the interaction of biological, psychological, and social cultural factors. The biological factor means that our brain has a reward system, and when someone uses substance, it can release dopamine and creating pleasure and reinforce the use of substance. And some people are genetically vulnerable. They are more likely, their brains are more likely to adapt to the substance they use and leading to a stronger craving feeling for the substance. And psychologically, people may learn that substance use behaviors from family or peers. That means if you have a family member who use substance, you are more likely to have access to it, and you are more likely to become addicted to it. And then in some countries, they may have beliefs like using substance can help me relax, or substance can help me cope with stress. This can also increase the risk of substance use disorder. And then traits like impulsivity or thrill seeking also heighten vulnerability. Social cultural factors means family dynamics, social stress, and cultural norms shape both risk and recovery. In some cultures, moderate drinking is normalized. In others, it's strictly prohibited, and that difference along changes population level outcomes. And there are gender differences here. Men often show higher rates of substance use disorder, partly due to social acceptance and personality traits like impulsivity. And women's substance use often begins in relational contexts, such as through partners, and they may develop dependency more rapidly due to biological sensitivity. Understanding these layers, biologically, psychologically, social, and gender, is key to designing fair and effective prevention and treatment strategies. And that brings us to the next step. How do we usually treat SUD in a way that acknowledge all these dimensions? The treatment here are complicated because relapse in this disorder is very common and no single approach works for everyone. The most effective treatments are integrated, combining biological, psychological, and social interventions. Biologically, we use medications, which can reduce cravings, ease withdrawal, or block the rewarding effects of substance. And medications are most effective when combined with therapy and social support. Psychologically, therapies like cognitive behavioral therapy is often used. They can help people identify their triggers, develop coping strategies, and challenge the belief that substance relieve stress. And another psychological therapy we use here, it can build readiness to change. And then we also have the contingent management, which reinforces abstinence through positive incentives. Social reintegration means family support, peer groups, and community programs help rebuild purpose and belonging. Key factors in long-term, these are key factors in long-term recovery. People are more likely to maintain recovery when they have structural meaning and connection. Uh, Now that we've explored what SUD is, why it happens, and how it can be treated, we can start connecting the dots to see how stigma and SUD interact. That's when we will turn to the next section, the consequences and the interplay between these two forces. So here, stigma can deeply affect people with SUD on multiple levels. First of all, it lowers self-esteem and self-efficiency, creating what's someone sometimes called white try effect. That's people feel there is no need in pursuing goals or recovery. And it can also generate fear, shame, social withdrawal, so people avoid social contact with others. And then it reduces willingness to seek or stay in treatment because of the judgment or discrimination they face during the process. Uh, when stigma is internalized, it reinforces hopelessness and blocks both recovery and goal pursuit. These effects are amplified by structural barriers. So we will look at the barriers to treatment next. Uh, they do. There are several barriers here, and the first one being the limited access to treatment programs, the high cost and restricted insurance coverage, and then we also may people with SUD may face the attitudes that the health providers give. So that means providers' attitudes sometimes are biased, resulting in low quality care and reduced engagement. Criminalization and punitive policies deepen social exclusions, discouraging people from seeking help. Structural stigma reinforces inequalities, leaving behavioral health underfunded compared to physical health. Beyond external barriers, stigma can also affect how people see themselves, which has profound consequences for recovery. So that leads to the internalized or self stigma. Internalized stigma or self stigma often occurs when people absorb public judgments. Uh, Awareness of public stigma can lead to someone believe that they may be weak, mentally weak, or flawed. Shame, guilt, and feelings of unworthiness reduce confidence and motivation. Again, these can contribute to the why try effect. They may not want to seek help eventually. And more importantly, building stigma resilience can help restore self-worth and support recovery. It's not just about removing stigma in the society, supporting the individual's sense of self is equally critical. Uh, Stigma also creates a ripple effect. Families bear an emotional burden, experience strained relationships, and may feel shame or reduced capacity to provide support. Communities can react with social exclusion or not in my backyard, NIMBY in short attitudes. That means they resist treatment facilities to be built in their neighborhoods. Public health suffers when treatment is delayed, relapse rates rise, and disparities increase. Uh, so, as the diagram on the right shows, stigma spreads outward from the individual to the public health system. And this is how stigma and SUD reinforce with each other. Stigma and SUD have a bidirectional relationship. Stigma can worsen SUD onset and progression. Experiencing stigma, SUD often triggers further stigma from society. This is magnified by self-stigma. Uh, it lowers self-esteem and motivation, leading someone to give up on goals. And social exclusion further isolates individual, increasing risk of continued substance use and preventing help seeking. And we have a loop, a circle in action here. So stigma leads to the social rejection and shame, and the isolation increase the likelihood of continued substance use, and then substance use will then triggers more stigma. So the feedback loop blocks recovery, shame and low self-efficiency reduce treatment engagement, and isolation here undermines long-term success. This also highlights why people with SUD are often treated differently than individuals with other mental illness. So compared SUD with other mental illness conditions, mental health conditions, people with SUD often face moralization or blame. Society tends to view SUD as a personal failure rather than a medical condition. Communities may resist treatment facilities due to the not in my backyard attitude, and then policies may focus on punishment rather than supporting their recovery. SUD is also perceived as more dangerous and unpredictable, which leads to lower support for medical intervention and a greater reliance on punitive approach. Understanding these distinctions is critical for designing intervention that effectively support people with SUD. So, stigma is influenced by intersectional factors such as media portrays, personal experience, and structural inequalities. Media sometimes emphasize untreated or criminalized individuals, reinforcing negative stereotypes. And contact and experience sometimes can be positive, but poor contact sometimes can worsen the situation for people with SUD. And then race, class, culture compound stigma for marginalized group and affect access to care. Other factors include knowledge gaps among healthcare providers and the public, and stereotypes of dangerousness, unpredictability, or blame. Taken together, these factors show that stigma is multi-layered, pervasive, and self-reinforcing, highlighting why addressing it requires more than one intervention. Uh, we talk about what is stigma and what is SUD, how they interact with each other, and now we will move on to the strategy, success, and emerging approaches to reduce stigma. So, reducing stigma generally involves two approaches. The first one being service agenda, which focus on treatment and care. This is led by providers and families, and this approach aims to normalize help seeking and make treatment accessible and acceptable. The second one being rights agenda. It focuses on the anti-discrimination and equity. It's led by advocates and peers. This approach works to challenge systemic injustice and ensures that people with SUD are treated fairly in law, policy, and everyday life. These two agendas approaches are both necessary, and treatment alone isn't enough if stigma persisted in society, and advocacy alone won't help someone already struggling to access care. And here are some key anti-stigma strategies. First being education. We can correct misconceptions and provide accurate information about SUD, basically meaning that we need people to learn that SUD is a medical condition rather than a moral problem. And then contact, meaningful interaction with people in recovery, reduce fear and negative stereotypes. The third one is language. Use first-person, non-stigmatized term matters because word can shape attitude. The fourth one is peer support. People with lived experience act as role models and mentors, showing recovery is possible. And then finally is the advocacy and policy change. Ensure equitable treatment, tackle structural barriers, and reinforces the other strategies. These strategies often work best in combination rather than in isolation. And beyond individual level approaches, policy and advocacy are crucial for sustaining long-term change. For the laws, we can do like anti-discrimination statutes protect the rights of people with SUD. And for zoning and facility planning, we can help reduce not in the backyard resistance to treatment centers, and for funding and incentives, support treatment access and evidence-based programs. Cross-sector collaborations means that governments, health systems, NGOs, and communities working together can amplify the impact. So here are some global success stories, and there are three of them. The first one being the Time to Change. It was based in England from 2008 to 2021. It used media campaigns, events, and community contact to reduce us versus them thinking, increasing openness and support. The second one being the Open Minds campaign in Canada. It leveraged contact-based education with recovery stories targeted to use healthcare workers, employees, and journalists using data to continuously improve. And the third one being the Beyond Blue, it's based in Australia. It implanted mental health literacy programs in school and primary care. So this is the campaign and country, their activities, and their key findings. So these examples both all highlight that reducing stigma requires sustained multi-level effort and combining education, personal contact, language changes, peer support, and policy altogether. And then, as I mentioned before, language is powerful here. So instead of saying someone is an addict, we can say that this person is with SUD, and instead of saying this one comes clean, we can say that he or she is in recovery. And these choices, they show respect and solidarity, and they remind us that people are more than their condition. When healthcare providers, media, and everyday communities consistently use non-stigmatizing language and gradually shift social norms, making it easier for people with SUD to seek help and feel included. But language isn't enough. Reducing stigma is a collective responsibility. Challenge our own biases and speak up when you hear stigma. And in the family, we can reduce shame, we can support loved ones and model acceptance. In the communities, we can foster inclusion, support local treatment initiatives, and counter not in my backyard attitudes. And for the whole societies, we can promote fair policies, responsible media practice, and public awareness campaigns. When all these levels work together, we create an environment where people with SUD can seek help, recover, and participate fully in society. So these strategies focus on substance-related disorders, and the same principle apply to behavioral addictive disorders. So next, we will explore gaming disorder. And I actually wasn't involved in the writing of this chapter, so I will just give a brief introduction here. And it's basically, I think, it's similar to the stigma in general and the stigma related to the substance use disorder. So first of all, what is gaming disorder? Gaming disorder is recognized by World Health Organization as a behavioral addiction. Its core features are these. First of all, is the impaired control, and then priority over other activities, continuation despite harm. Diagnosis of gaming disorder focus on life impact, not just hours spent on gaming. DSM-5 does not have a diagnosis of gaming disorder. It lists this type of symptoms as internet gaming disorder for further study. So this part, the authors draws on a scoping review of 32 studies from 17 countries between 2009 and 2024. And these 32 studies were chosen for their focus on gaming disorder and the social stigma associated with it. And then So the method allows a broad overview rather than a quantitative meta-analysis, which is appropriate given the emerging nature of gaming disorder stigma research. Uh, as you can see here, the stigmas toward the manifestations of gaming disorder stigma also includes labeling stereotypes. It is similar to the stigmas I mentioned before. Stigma towards people with gaming disorder appears in several ways. First, the labeling here. Individuals are often called addicts or lazy due to their gaming habits. Secondly, stereotyping. These labels are linked to negative assumptions, such as being socially inept or morally weak. Third, social distancing occurs when family, friends, or society withdraw support, criticize, or isolate the individual. These reactions can fuel feelings of shame and isolation, making it hard for individuals to seek help. The cause of gaming disorder stigma are multifaceted. Uh, Media also plays a huge role here. It often emphasizes the sensational stories of gaming harm, which reinforces negative perceptions. Many people morally judge gamers, viewing excessive gaming as a personal failure rather than recognizing it as a behavioral addiction. You can see the similarity here. Like for people with SUD, they see it as a moral failure rather than a medical condition. Here, the gaming disorder is seen as a personal failure rather than a behavioral addiction. And then finally, the general lack of awareness, even among professionals, about the psychological and social complexity of gaming disorder contributes to misunderstanding and stigma. Uh, the consequence of gaming disorder stigmas includes emotional level, social level, and then eventually the recovery or help seeking process of the individual. For the emotional, it generates shame, guilt, and lowered self esteem. Socially, it may cause isolation and strained relationships with family or peers. Critically, stigma acts as a barrier to help seeking. Individuals may avoid professional treatment or support services due to fear of judgment. Addressing stigma is therefore crucial for both prevention and recovery. So that's actually all my presentation here. Thank you all for your attention and your time. Today we've covered substance use disorders and stigma and how stigma affects recovery and strategies to reduce it. We also touched on gaming disorder and its associated stigma. Overall, the presentation here shows how stigma impacts individuals, families, and communities, and reducing it is a shared responsibility. And I want to thank you all again for giving me this opportunity and for your time. Well,
Thank you very much, Yifan. This was really a great presentation. I really enjoyed it. You gave
thank you.
a great overview, and I think it's wonderful how you treated this topic. So before giving the floor to our audience in general, I would like to give the floor to Hang Su, who has
Mhm.
been the editor of the book on the book Breaking the Silence. Hang Su, maybe you would like to add something and also to explain how you came to this topic.
Yeah, thank you very much. Thank you, Yifan, give a very excellent talk. And I must thanks to all the authors of this book, especially Yifan Xu and Chang Yishen and other authors. They contributed a lot to this book, and we think this book is very useful for our social workers and drug or other workers for under the for treating drug use disorder or gaming use disorder in all this field in hospital in university and I think this book is a very useful tool for everyone and then Yifan Xu made a lot of contribution to this book. I must thank her very much. Yeah, yeah. she wrote a lot of part of this book, and she's very special because she is she worked in as a social worker in our hospital for several years, and she graduated in uh, America, and she studied social work in America. Yeah, she's very excellent, and we can if we can I hope maybe next time we can invite her to our Solid project and to join us to talk about how to do social work in drug addiction. Yeah, thank you very much. Yeah, okay.
Thank you. Yeah. Now I would like to give the floor to our participants. So who would like to ask a question to Yifan and to Hang Su? Any questions to the presenter?
Or any comment? Yeah.
Comments is also fine, yeah. So maybe I can make a start. I really liked the way you tackled stigma from the individual and the structural level. And I would like to learn more about stigma in the healthcare system, because this is
Mhm.
something that we talk about a lot. So to what extent do medical workers, medical doctors, but also social worker stigmatize clients? And how can this structural stigma in healthcare institution be yeah, overcome? Maybe you have some thoughts about this. Thank you.
I do have some thoughts about it, but since this video is going to be uploaded to YouTube, I don't know if I can say it. Anyways,
Mm,
I mean, um, so as I mentioned before, we work at my job at the Shanghai Mental Health Center is I work as a medical social worker, and I also work as the research assistant there. And the thing is, we have a gambling uh
Group
prevention group,
group.
something like
Yeah,
that.
yeah.
And then uh not a lot of people knows about this group, so that's I think it's not only for structural stigma, it's like the public stigma. First of all, gambling is not a substance use disorder, it's like more a behavioral addiction, but then it's related. uh and then people think gambling is more like a moral failure, not a medical condition, but indeed gambling disorder is a medical condition, and we do have this diagnosis criteria in ICD-11. We can make diagnosis of gambling disorder, but a lot of people in China do not know this condition, and they think gambling is something you can control by willpower or something like that. And then for the group here, we sometimes when we introduce this group to other patients or other uh, professionals, they will think, is this really necessary for them to have this group in your facility? And I think that's the problem here. That's something we can categorize as structural stigma, because they do not think, even professionals, they do not think it's necessary for these people to seek help. And that's my thought on it.
yeah, thank you very much for sharing this thought. Um,
Mhm.
I was attending a meeting a couple of weeks ago, and something similar was mentioned there. So, what a lot of organizations are actually struggling with in Germany is that people with SOD, that they show increasing mortality. So more people are dying with SOD than a couple of years ago. And one issue is that when they have medical issues, they are not, I mean, they are not treated, or they find it difficult to access a medical doctor or medical doctor. So it can go both ways. So that's internalized stigma, or that medical doctors, like put everything, all medical problems on the disorder, instead of maybe looking whether there are other diseases. So and this then results in the problem that people might die of cancer or another disease that in principle is prevented, but they just do not get treatment in time. Yeah.
Mhm.
It's also connected to the fact that poor people or like find it more difficult to access the healthcare system. So a lot of different factors are involved, but it's stigma can also lead to increased mortality and morbidity in other aspects that are not
Mhm.
really connected to the SOD. Yeah.
Since you mentioned that, because using substance or drugs in China, illicit drugs in China is a crime.
Mhm.
So sometimes people are afraid to go to hospital to seek help. And from from my from my perspective, I think some people may hide away, may refuse to go to hospitals to get treatment because they are afraid they are going to be arrested or something like that.
Mhm.
So that's
I
another way
see.
of how structural stigma and self stigma interacted with each other.
Mhm. Yeah. You also mentioned this specific notion of the face and losing body
Mhm.
weight. Maybe you
Yes.
can tell us a bit more about this because it's also fascinating how
Yes.
this
It's
works in different
actually an
cultures.
anthropological view. I actually had a major in anthropology, so that's why I'm interested. Let's get to the slide first. Not this one. Mhm. Yes. So here, the face in China is face directly translation. The direct translation of 面子 is face. I don't think there is a word you can describe it in English. 面子 means, I don't know. It's just like something. If you lose the face, you are not losing the face of yourself. You are losing the face of the whole family. Something like that.
Mhm.
We do have a strong family sense in China or kinship sense in China, something like that. And then 丢面子 is more like
自尊有点像自尊这个意思吧？一般自尊怎么翻
yes,
译？
self-esteem. But it's not really like self-esteem.
Yeah.
It's it's just like so do you want to know the relationship of 面子 face with and stigma or something like that, right? You want to know something like this, right?
Yeah, I was just really interested in how different cultures approach this,
Mm-hmm.
because I think we discussed it also in the context of Central Asia. So in any culture, the behavior of one person relates to the family and the sibling, the parent, the children, depends on, yeah. And then um, this is, I think, what you also call the ripple effect, yeah. So it's not only the individual person, but also the environment. And I think we discussed it that these family ties in Central Asia, yeah, they can be a protective factor so that family can actually support and sustain the individual and help and support the individual. But um, it could also be a destroying factor. You see, where you have this strong collective identity, and then you have one person showing deviant behavior, and it affects the whole family. So yeah, I think Aijan would like to add something to this. I think it's interesting.
Yeah, I also wanted to add about this stigma issue. So if we will talk about relationship between a person who is using substances and his or her family, it's sometimes more like when family is trying to hide this and thinking that this is not something that you can share with the society, this is the main one of the main reasons why people self stigmatize themselves. Like it's very difficult to approach to society or other people who are sometimes can support you if even your family is not accepting you as a person who needs some support, or because you are representing especially for example, this is a key for teenagers. Sometimes they are like psychological trying to be more separated from their parents, but in another way they are more evaluating themselves through their parents, and when parents are not really able to accept them, so this is really the key point when
That's
they are
what
starting to self-stigmatize themselves. So like from the perspective of society, sometimes it's not very positive, and like to the like plays not a very good role for the support and the treatment.
Thank you. Thank you. Yifan,
as
you
she mentioned,
oh yeah.
acceptance in her view, and that's what means about it, and family too. And it's basically it's not about the person, it's about the whole family here. And I mentioned 面子 here because it's a moral concept in China. So that's why it's linked to stigma, because uh it it affects the morality and the identity of the person, and then not only the person but also the morality and identity of the whole family. So the family member will be ashamed of this person if he or she or they are using substance in China. So that's the whole concept I mentioned face here.
Thank you. And you also mentioned peer groups. And so peer groups, I would like to learn more about this because in like for instance in Germany you have peer groups for different kinds of SODs. So you have, for instance, anonymous alcoholists, but also anonymous narcotics groups where people come together that are in a similar situation and
Yes,
share.
and
Mhm.
no, I mean, as I mentioned before, like the substance use here in China is illegal, and then we do have a gambling group here, but it's not. It's like a peer group, but it's not like AA or NA in Europe or in America. They have a lot of NAs and AAs, and you can host it in the church, in anywhere you want. But in China, these groups are meant to be in medical condition, medical settings, which means that it can only be held in the hospital settings. Basically, in China, or a facility with psychological licenses. So it only can be hosted in a psychological facility or or a hospital like ours. So yes and no.
I see. So it's a bit different. It's
Yes.
yeah, because you know what I know from Germany is that in many cases it's the easiest way to get support. You see, because if you have oh, I'm sorry. So if you have a condition and um, sometimes it takes a long time before you actually can get um, into treatment. And medical doctors even advise people to join such a group because this is what they can do right away. Yeah, they do not need to wait, or they do not need to wait for the funding and stuff like this, because going into treatment is much more difficult in many cases.
Yes. In our cases, we in our hospital we have a gambling peer group right now for like it started since 2021. That's not too long ago. It's probably 4 years now. And then we had a AA group, a alcohol support peer group. But then because of the culture in China, the use of alcohol is more acceptable here. So people does not consider drinking alcohol as a very serious condition. So the group just closed because of we do not have enough patients. But then the thing is, we do have a doctor who will recommend patients to our groups, and this doctor will also prescribe medical medicines to the patients if he sees these patients are fit for medications.
I
So
see.
we do provide a medical approach and psychological approach at the same time. But then the leader of the group is not a peer. We do have a mentor support who is an role model in some sense, because this person has successfully stopped gambling for more than 3 years now, I think. And then he is the role model in the group, but the leader of the group is a licensed psychologist.
I see. So it's more embedded. I mean, this is also very
Yes.
good. Yeah.
Yes.
Thank you. Are there more questions or comment to our presenter? Anything else you would like to add? Just waiting a moment.
So maybe just it will be one comment from me.
Mm-hmm.
As I already mentioned, so we have some common things that I could see even from our kickoff meeting when we were discussing with one of your colleagues. We have like a lot of commonalities in our sometimes legislation, cultural stuff, and so on. And overall, I just started reading this book, so I just wanted to say thank you for your work, and I guess it will be really helpful. And it's for me, or at least helpful to identify that we cannot now say addicts, like addicted people and so on. Like we need to be like careful when we are also like talking about these people and with these people. So yeah, it was really maybe simple stuff, but still very helpful. Thank you.
Yes, thank you. That's what I want you guys to learn from this session, to say people with SUD rather than addicts.
Thanks a lot. And also many thanks for reminding me of mentioning that the book is open access. So if you would like to read the book, you can exit it from the publishing house website and also from the Solid website. So yeah, make use of it. You can also use it for teaching. And thanks a lot for writing the book. It's really very nice that we have it and that we can work with this and learn from you. So thanks a lot, everybody. I will stop